let us look at immune deficiency. We're going to be looking first at B and T cell defects and then at phagocytic defects. And as you can tell, these concepts are very high yield because of the clinical angles that they have for your examinations. So next to hypersensitivities and next to RH incompatibility and ABO incompatibilities, these concepts are going to be very high yield for your exam. So pay a good attention and make sure that you lock in information about them as we go on. Let's begin with a starter case scenario. An 18-month boy is evaluated for recurrent pneumonia, otitis media, and erysipelas for more than 10 months. The patient has a 6-year-old sister. He had a brother who died at age 12 months with similar symptoms. His 2 siblings were from the same parents. He has been vaccinated for rubella, measles, diphtheria, and tetanus. His serology, however, shows no IgG antibodies against these vaccinations, and it is significant for undetectable levels of IgM, IgG, and IgA. Total lymphocytic count of the peripheral blood are within normal range. CD3 T lymphocytes are within normal range. There are no detectable CD23, CD19, and CD20 cells. Of course, as you can tell, at this point I want you to identify these important markers and be ready for it, that what types of cells express these proteins. The question that we are about to explore is this: which of the following mechanisms best explains these findings? Of course, this is a double jump question. First, you have to do the diagnosis, and then you have to find the mechanism. You have a boy in the case scenario. The brother died. The sister is almost normal. So you're going to be looking at an X-linked condition. So far, you have figured this one out, and the patient is not producing antibodies, and you don't see IgM, IgG, and IgA. However, the T lymphocytes are okay. So as you can tell, we are looking at a B cell defect in this case scenario. Let me give you the correct answer at this point. The correct answer is defective BTK enzyme. To just orient you and give you a high yield chart in the table, on the left side column, I'm showing the mechanism and I'm showing the name of the associated disease, and we're going to cover all of them for you in this segment. Now, the WASP gene mutation is associated with Westcott-Aldrich syndrome. We're going to cover this syndrome also in hematology. STAT3 mutation is associated with hyper IgE syndrome. Interleukin-12 deficiency, of course, as the name implies, disease is interleukin-12 deficiency. CD40 protein deficiency causes hyper IgM syndrome. And the best answer, defective BTK protein, is associated with X-linked Agammaglobulinemia. This is the condition that this 18-month boy must have had. Before I go further, let me orient you of what we have to do. We're going to be looking at immune deficiencies. We're going to be looking at B cell disorders, T cell disorders, combined B and T cell disorders, and finally phagocytic disorders. To orient you in this diagram, in the bone marrow, we're going to have these stem cells. These stem cells are going to make in the bone marrow the lymphoid and myeloid progenitors. Lymphoid progenitors are going to be evolved into B and T cells. Of course, T cells mature in the thymus and B cells in the bone marrow. From myeloid progenitor, we're going to make essentially the neutrophils and macrophages and granulocytes, and these are going to be of interest to us when we deal with phagocytic disorders. The conditions that stem from T-cell defect include DiGeorge syndrome, hyper IgE syndrome, interleukin-12 deficiency, and chronic mucocutaneous candidiasis. Conditions that stem from combined T and B cell defects include severe combined immune deficiency, ataxia telangiectasia, Westcott-Aldrich, Almond syndrome, and Bloom syndrome. Conditions that specifically are related to B cell deficiencies are X-linked Agammaglobulinemia, selective IgA deficiency, hyper IgM syndrome, and common variable immune deficiency. Finally, from a standpoint of phagocytic disorders, we're going to be interested in Shediac-Higashi, chronic granulomatous disease, leukocyte adhesion deficiencies, interferon gamma receptor deficiency, and congenital neutropenia. So as you can tell, the list that I have provided to you here is a very high yield list, and we're going to be covering all of these conditions in what follows hereafter. Let's first begin with the answer to that case scenario that I just covered for you. And of course, this falls under the umbrella of B cell defects. This is X-linked Agammaglobulinemia. Another name for the condition is Bruton type Agammaglobulinemia or Bruton's syndrome. Defect, luck in the name of this gene, is in BTK gene that stands for Bruton tyrosine kinase. This enzyme is required for maturation of B cells in a bone marrow. It mediates this function through a signaling effect via BTK protein on the B cell receptors. As a result of this defect, there is a block in B cell development at the pro-B to pre-B cell stage. Remember, pre-B cells are more specialized than pro-B cells. As we covered earlier, this is an issue that is confusing to students. We start from pro-B cells to pre-B cells, and then we get to naive B cells, and then we get to the effector cells. Note that when this gene is mutated, the immature pro-B lymphocytes are unable to develop into pre-B lymphocytes. Also note that normally pre-B lymphocytes have to develop into mature naive B cells, and then they leave the bone marrow and enter the bloodstream and get into the lymph nodes. What types of symptoms and findings do you see in these patients? The disease is seen in sons of asymptomatic mothers. Patients present with reduced levels of all immunoglobulin isotypes. They are diagnosed after 6 months of age as a result of recurrent bacterial infections. These children characteristically do not have tonsils or adenoids. Luck in this information. To just refresh your memory, I've already presented this picture to you before. In this X-linked condition, due to BTK gene defect, there is a block in B cell development at the pro-B to pre-B cell stage. As a result, immature pro-B lymphocytes are unable to develop into pre-B lymphocytes. How do we diagnose the condition? Diagnosis is based on symptoms, lack of tonsils or lymph nodes, complete lack of serum immunoglobulins, lack of B cells, and classic B lymphocytic markers. Those are CD19 and CD20, and absence of BTK protein in monocytes or platelets. Treatment includes intravenous immunoglobulin or pooled immunoglobulin administration. Live vaccines are contraindicated in these patients because these patients cannot mount essentially B lymphocytic response and cannot make immunoglobulins against live antigens. Let's quickly review the basic facts about BTK enzyme. This is a member of TEC family, TEC family of kinases. Activation of BTK results in a cascade of signaling events resulting in calcium mobilization and fluxes, cytoskeletal rearrangements, and transcriptional regulation involving nuclear factor kappa B, the abbreviated term for it is NF kappa B, and nuclear factor of activated T cells, NFAT. This activation is tightly controlled by several other signaling proteins, including protein kinase C and caveolin 1, which is a membrane protein expressed on most bodily cells. Anyhow, a few facts for you to remember. The exam is not heavy on these, but for those rare questions on the exam, it's good to familiarize your eyes and ears with these essentially proteins and names. To give you a good mnemonic here, with stress on letter B, in X-linked Agammaglobulinemia, Brotons, there is a defect of BTK and lack of B cells and B markers, and pro-B cells do not turn into pre-B cells, and there is lots of bacterial infections that they surface after 6 months of age when the IgGs that arrive from placenta are tapered off in the body of the baby. Let's look at this case scenario. A 2-year-old girl is admitted to hospital with severe pneumonia. History shows that she had no significant medical history until 8 months of age, when she presented with an episode of severe interstitial pneumonia and pneumothorax. At the time, examination of fluid specimens from pulmonary drainage identified infection with Pneumocystis carinii, and she was treated with antibiotics. Her mother states that starting at 8 months of age, she had frequent episodes of upper respiratory tract infections and otitis media, and in all cases she has been treated with antibiotics. Current serology of the patient is positive for IgM antibodies against Mycoplasma pneumo. Immunological studies show no traces of IgG or IgA antibodies in her serum. What is the most likely mechanism for these findings? Purine nucleoside phosphorylase deficiency, NADPH oxidase deficiency, CD40 ligand deficiency, STAT3 gene mutation, interleukin-12 receptor deficiency. Of course, test strategy tells me that I have to lump these answers into 2 groups. A and B are mostly related to phagocytic dysfunctions, and the best answer for this question most likely must be seeked among the options C, D, and E. Let me give you the correct answer at this point, and the correct answer is CD40 ligand deficiency. To orient you again and give you a high-yield fact, essentially this table, the facts in this table for your exam, the purine nucleoside phosphorylase deficiency causes SCID. We have also covered this from a different angle in your biochemistry. NADPH oxidase deficiency, again, is associated with chronic granulomatous disease. Again, we covered this in biochemistry. The correct answer for this case scenario, CD40 ligand deficiency, is associated with hyper IgM syndrome. So this 2-year-old girl has hyper IgM syndrome. STAT3 mutation is associated with hyper IgE syndrome, and interleukin-12 receptor deficiency, of course, is associated with interleukin-12 deficiency. This gives you a heads-up mnemonic for what comes next. Just to know, STAT3 mutation goes with hyper IgE, you turn around letter E, you're gonna make number 3. So that gives you a light mnemonic to use later. Let's talk about hyper-IgM syndrome, and I'm going to be referring to this diagram for you. And as you can tell, the interaction between Th2 and B cells involves CD40 protein on the B cells and CD40 ligand on the Th2 cells, and after proper matching, the Th2 cells are going to release interleukin-13 and interleukin-4 onto receptors for interleukin-4 and interleukin-13 on the B cells. This activates the B cells. Some of them turn into plasma cells, and of course the very first essentially immunoglobulin that they produce is IgM, and IgM, which is pentamer, I've said before, is membrane bound, and of course this interaction interleukin-13 and 4 release, and also the binding of the two ligands CD40 and CD40L also causes class switch in the B cells, and we're going to get different types of antibodies produced by the B cells. But anyhow, the diagram also shows you that this ligand effect is affected in hyper-IgM syndrome. As a result, class switching will not happen because the energy of the body is not devoted to other immunoglobulins. We're going to produce more than normal level of the IgM. So this diagram somehow orients you to what I have to talk about with regard to hyper-IgM syndrome. So this diagram will orient you to the pathogenesis of hyper-IgM syndrome. So let's go through this. Hyper-IgM syndrome actually is a closely related group of genetic disorders that all of them, they have one common denominator: high levels of the immunoglobulin M. As you can tell by looking at this diagram, this condition may be due to defect of CD40 ligand on Th2 cells, or it may be due to CD40 proteins on the B cells. The most common form results from a defect in Th2 protein, which is CD40 ligand. And the second most common form is due to CD40 expression on the B cells. The disorder causes frequent susceptibility to various types of infections. The patients often have a low number of neutrophils and platelets as well. I want you to note that IgM is the initial antibody that B cells produce. However, after exposure to their cognate antigens, they undergo class switching and make IgA, IgG, and IgE. This is something that doesn't happen in these patients. Ordinarily, proper defense against pathogens requires presence of several isotypic forms of antibody against invading pathogens. For instance, the IgA against the same epitopes defends against the future invasion of the mucosa, and IgG targets the same antigen in the blood. In patients with hyper-IgM, the B cells produce an extremely high amounts of IgM because they are unable to perform class switching to other isotypes. This results in an overproduction of IgM antibodies and underproduction of other isotypes. I want you to know that CD40, the ligand on Th2 cells, is a co-stimulatory molecule for B cells and helps them to class switch from membrane-bound to secreted antibody form. Treatment involves pooled immunoglobulin injection. CD40 on Th2 cells is a co-stimulator molecule for B cells, which helps them to class switch from membrane-bound to secreted antibody forms, locking this high-yield information. Next case scenario. A 16-year-old boy incurs an open tibial fracture during a mountain biking accident with his family in a tropical country. A tourniquet is placed immediately below his left knee to to minimize bleeding, and he is taken to a nearby hospital accompanied by his parents and 2 siblings. On admission, the patient is pale and in pain. He is oriented and can respond to questions. His mother states that his son has never had any accidents before. However, he has had frequent sinus, lung, and GI infections throughout his childhood. It is determined that he should undergo immediate operation, and prior to the operation, he was provided with red blood cell compatible blood transfusion. 20 minutes into the transfusion, he develops chills, nausea, vomiting, hypotension, and goes into shock. Which of the following serological findings prior to blood transfusion would have pointed to the etiology of transfusion reaction in a patient? Low levels of B lymphocytes, low levels of CD4 T cells, CD4 positive T cells, low levels of CD8 positive T cells, IgA deficiency, or IgG deficiency. Again, the boy is 16 years old. This case is a classic case, and I had reasons to give you this case and facts. The patient has had frequent sinus, lung, and GI infections, and there was something about the transfusion that he received that flipped on the response in this child. I will give you the correct answer right now, and then we're going to make sense out of this information. Again, that frequent sinus, lung, and GI infections will bring your attention to IgA deficiency, because these patients are more at risk for mucosal sort of infections, and for GI and respiratory infections. But the question that we do still need to answer, and I want you to know the mechanism of it, is that why, quite often incidentally, we identify this when the patients get blood transfusion, and why they get such a serious reaction. So that's the fact that I want you to lock in. For now, the history of frequent GI and upper respiratory and sinus infections supports diagnosis of selective IgA deficiency. IgA deficiency is the most common immunodeficiency in the Western population. Patients with IgA deficiency are at risk of developing severe reactions after receiving blood products due to reaction of IgG anti-IgA antibodies and IgE anti-IgA antibodies of the recipient with IgA molecules of the donor. Lock in this information. The incidence of transfusion reactions may be reduced if the patients receive washed red blood cells. Also note that IgA deficiency is commonly associated with normal B lymphocytes in peripheral blood, normal CD4 positive and CD8 positive T cells, and normal neutrophilic and lymphocytic counts. These patients quite often have anti-IgA antibodies of the IgE and or IgE isotypes in their serum. Lock in this information. IgA deficiency, as we said earlier, is the most common immune deficiency in Western countries, affects 1 in 600 patients. Familial inheritance has been recognized in 25% of affected individuals, so quite often there is a family history. The disease results from a defect in B cell maturation or class switch to IgA. The exact immunologic pathology is not yet well understood. Many patients may be asymptomatic and are diagnosed coincidentally during screening for healthy blood donation or after seriously reacting to blood transfusion. This was the case with the case scenario that we just covered. IgA plays an important role in defense against mucosal diseases. The patients often have a history of frequent sinusitis, respiratory, and gastrointestinal infections. They also characteristically present with giardiasis. Characteristic serologic findings are anti-IgA, IgG, and anti-IgA, IgE antibodies. Upon transfusion or intravenous immunoglobulin administration, these patients may present with serious anaphylactic reaction due to anti-IgA, IgE antibodies. And this is something that our patient had in that case scenario. Low IgA in blood or washed red blood cells are preferred for these patients. So if these patients have to receive transfusion, you want to give them washed red blood cells. Very important association, and we have covered this in details in pathology, is celiac disease. Let's look at the next B-cell defect, which is known as common variable immune deficiency, CVID. CVID is a relatively common immune deficiency and affects 1 in 25,000 persons. Defect is related to B and T cells and most probably related to plasma cell development. This results in increase in all types of secreted immunoglobulins. However, the patients may have variable levels of immunoglobulin deficiencies. Some may present with low IgA and IgM, 50% of the cases. Some may present with low IgG and IgA, and others with low levels of all isotypes. Hence the name variable immune deficiency. CVID is often diagnosed during the 3rd or 4th decade. Lock in this information. This is the key phrase on the case scenarios that will provide to you on the exam. They are often diagnosed as a result of bronchiectasis subsequent to frequent lung infections. So you already have a few must-know high-yield facts. Frequent lung infections and the age of the patient. Variable levels of the antibodies. These are the key words on the USMLE or COMLEX exam that you have to look for to diagnose this disease. History of patients is often significant for multiple past episodes of otitis, sinusitis, bronchitis, pneumonia, autoimmune diseases, granulomatous reactions, and tumors such as lymphomas. The macroorganisms that are frequently isolated in the patients are Haemophilus influenzae, Streptococcus pneumoniae, Staph aureus. The less frequent pathogens are Neisseria meningitidis, Pseudomonas aeruginosa, and Giardia lamblia. These infections respond well to antibiotic therapy. However, they tend to recur after cessation of the therapy. About 20% of asymptomatic patients may be diagnosed in childhood after serologies that confirm immune deficiency. Note that due to slow development of immune system, the definitive diagnosis cannot be made until after the age 4. 50% of the patients present with autoimmune diseases such as pernicious anemia, idiopathic thrombocytopenic purpura, psoriasis, rheumatoid arthritis, and primary hypothyroidism. Commonly associated malignancies in these patients include non-Hodgkin's lymphoma and gastric carcinoma. Lock in this fact also. 2 additional sets of findings in the case scenarios on your exam is associations with autoimmune conditions and association with malignancies such as lymphomas and gastric carcinomas. A 3.5-month male is admitted to the clinic after an episode of generalized tonic convulsions. History shows that the baby was diagnosed with atrial septal defect at the time of his birth, and he went to the clinic about a month ago for a complaint of purulent rhinitis and maculopapular rashes. Her mother says that she had difficulty breastfeeding him since the time of his birth. She further claims that this is the third time that her baby has suffered from seizures. On examination, the baby has a lack of generalized alertness and has a very low weight compared to other babies of his age. Serology shows normal alkaline phosphatase and low serum calcium. Is treated with a special formula that provides a 2:1 calcium to phosphate ratio. Which of the following immunologic lab findings is most likely present in this patient? As you scan the options, you're going to see several markers that are markers of T lymphocytes or B lymphocytes. The question is a double jump question. Findings of generalized convulsion, history of septal defects at the time of birth, history of infections and purulent rhinitis, difficulty with feeding, seizures, low weight, low serum calcium, and the fact that the treatment includes a formula that has 2:1 calcium to phosphate ratio might have alerted some of you to think about DiGeorge's syndrome, and if you've done so, you are on the right track. In these patients, we have low CD3, CD2 positive cells. These are T lymphocytes, and we have low CD19, CD27 positive B lymphocytes that are mature B lymphocytes. To orient you a little, and it's a good idea if you can remember these CD markers for your examination. All B cells have CD19. All T cells have CD3 and CD2 markers. Natural killers have CD16 and CD56. Immature B cells, in addition to CD19, they have CD10. Mature naive B cells, in the lymph nodes, they have CD19. Memory B cells, they have CD19 and CD27. To give you a mnemonic at least for the B cells, remember B for boy, let's say, think of a boy at age 10, still immature, at age 19, gets mature, and then goes to the college and medical school and remembers so many facts and subjects those facts to his memory, and now the age is 27. Anyhow, this gives you a light mnemonic to remember the markers for the B cells. As I said, the patient has thymic aplasia that is also known as congenital thymic aplasia or DiGeorge's syndrome. This condition results in impaired T cell maturation and function. B cells, or CD19 positive cells, and natural killer cells that they have CD16 and CD56 are mostly normal, but T cell numbers that are the cells that express both CD2 and CD3 are always decreased. Also, it is shown in these patients that CD8 positive T cell population is often much less than CD4 positive T cell in number. T cells are required for activation, maturation, and class switching of the B cells. Therefore, DiGeorge's patients often present with low mature B cells. Those are CD19 positive, CD27 positive lymphocytes. And that was the correct answer in this case scenario. Again, I want you to remember the markers for different stages of B cell development. Immature B cells are CD19, CD10 positive. Mature naive B cells are CD19 positive, however, they are CD27 negative. Memory B cells are CD19, CD27 positive. So let's discuss the DiGeorge syndrome. This is the first T cell defect that we are discussing. A good mnemonic for you to remember facts related to DiGeorge syndrome is this one, catch 22. And then I have here by, die, to 22. These patients have cardiac anomalies. This is C of the catch, abnormal faces for the A, thymic aplasia for T, and of course you can include the congenital cardiac anomalies such as truncus, arteriosus, and tetralogy of Fallot for the T as well. They have cleft palate, they have difficulty with feeding and maybe food regurgitation. They have hypocalcemia due to hypoparathyroidism, and the defect is on chromosome 22. DiGeorge's is also known as 22q11.2 deletion syndrome based on the location of the deletion on chromosome 22. There is failure of embryonic development of the third and fourth pharyngeal pouches. These patients have hypoparathyroidism. Make sure that your book says hypoparathyroidism. As a result of that, they have low calcium, and as a result of that, they have a frequent history of tetany and seizure. They have low T cells, and as a result, these patients have recurrent viral and fungal infections. Patients present with congenital heart and great vessel defects at the time of birth, and they lack thymic shadow on X-ray. Lock in this information for your pediatrics. Patients have a broad nasal bridge, long faces, narrow palpebral fissures, micronatia, and at times microcephaly. Facial features become more pronounced as the children grow into the second decade. Significant feeding difficulties are present in about 36% of the patients, including the patient that we covered in that case scenario. These may be due to poor sucking and nasal regurgitation due to velopharyngeal inadequacy VPI or cleft palate. So you have two other important findings for these patients because of the failure of closure of the pharyngeal pouches. Immunochemistry shows low CD3 positive T cells and low CD27 mature B cells that can express immunoglobulins. Remember again, mature B cells upon stimulation can express immunoglobulins or can change into plasma cells. Adults with DiGeorge syndrome are at risk for a particular debilitating mental disorders, and there is a great association between the two conditions. What is it? This is schizophrenia. I want you to know that about 30% of the patients with DiGeorge syndrome will have at least one incident of psychosis in their lives, and about a quarter of them will develop schizophrenia.